Thank you, Shauna. Today's webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with prior written consent of the AERC. Copyright 2015, all rights reserved. My name is Tom Kallstrom. I'm a registered respiratory therapist and the executive director of the AARC. I welcome you today to today's presentation, which is the PELICAN study, Improving Oxygen Compliance at Home. I'm very pleased to welcome Ms. Kim Wiles. Kim is a registered respiratory therapist and the Vice President of Respiratory Services at Kling & Smith Healthcare in Ford City, Pennsylvania. Kim is also the AERC Home Care Section Chair and is also on the Board of Directors of the AERC. And I'm also pleased and excited to welcome Dr. Jerry Krishnan. Dr. Krishnan is a professor of medicine and public health and the Associate Vice President for Population Health Studies at the University of Illinois Hospital and Health Sciences System in Chicago, Illinois. He's also the primary investigator for the PCORI-funded peer-led O2 info line for patients and caregivers, which is also called the PELICAN study. And that is what we'll be discussing today. So Kim and Dr. Krishnan, I welcome you to today's program.
Thanks, Tom.
Thank you, Tom.
And with that, Dr. Krishnan, I would welcome you to start your presentation.
Great. Well, thank you so much, Tom, and I want to thank Kim as well for the invitation to be with you today, and also very deeply grateful for this opportunity to talk with your membership, the American Association for Respiratory Care. What I'd like to present today is a very interesting project. It's a research study that we've just now begun to roll out, and this is an opportunity for us as researchers to work very closely with the American Association of Respiratory Care and with your respiratory therapists in the rollout. The name of the project is called PELICAN and stands for Peer-Led Oxygen Info Line for Patients and Caregivers. So what is PELICAN and what is this all about? Well, the story of PELICAN really begins a little over 20 years ago, if you will, in the landmark publication in Lancet, in a study that was conducted by the Medical Research Council. This was published in 1981, and this is really the first study that demonstrated to us that home oxygen can save lives. The Medical Research Council study, sometimes called the MRC study or the MRC trial, enrolled individuals who were less than 70 years old with a diagnosis of COPD as defined by chronic bronchitis or emphysema with an FEV1 less than 2 liters, who demonstrated resting room air hypoxemia as defined as a PaO2 between 40 to 60 millimeters of mercury. The study tested as a randomized clinical trial the use of home oxygen via nasal cannula for at least 15 hours a day in order to raise the PaO2 above 60 millimeters of mercury. In addition to the oxygen, those that were randomized to the intervention group were given home visits from time to time by research staff in order to check on oxygen usage, help answer questions that patients might have, and obtain ABGs. So patients randomized to the treatment group of oxygen received not only oxygen, but also home visits in order to help ensure that the oxygen was being used correctly. And they were randomized to what's called usual care. And the interesting finding from this study is that the trial was, far less than 100 patients. A total of 87 individuals were randomized into this protocol. And what it demonstrated definitively is that mortality was substantially higher in the usual care group. Looking overall the course of the study, groups that received oxygen and the home visits, their mortality was about 45% compared to the usual care group that had a mortality of approximately 67%. It's So this study demonstrated in a very small sample that oxygen can save lives if you have resting room air hypoxemia and you're prescribed to use oxygen at least 15 hours a day. What we don't know is how compliant people were when they used the oxygen. We'd have to wait for that for the next study. This was the second landmark trial that defined the field of oxygen use at home. This was published by what's called the Nocturnal Oxygen Therapy Trial Group in 1980, and this was a National Heart and Lung Blood Institute that enrolled 203 patients. In the NOT trial, as I mentioned, a little over 200 patients were enrolled. You have to be at least 35 years old, have a diagnosis of COPD, and have a post-bronchodilator FeV or FVC ratio of less than 70%. You also had to have resting room air hypoxemia as defined as a PaO2 of less than 55 millimeters of mercury, or you could have a slightly higher PaO2 of up to 59 millimeters of mercury if you have evidence of essentially cor pulmonale or polycythemia as a result of the hypoxemia. Patients who were in this trial, their oxygen was titrated to keep their PaO2 of at least 60 to 80 millimeters of mercury, and they received oxygen via stationary oxygen concentrators. And interestingly, these concentrators had timers on it, so you could actually measure how long the oxygen was being used from the concentrators. They also had liquid oxygen systems and compressed gas. Patients who were also using compressed gas cylinders were not monitored through objective adherence monitors, so there were no timers attached to these compressed gas cylinders. Both groups, whether or not there were, and I'll talk about the two groups in a minute, but all patients in the study had close follow-up care, including home visits by a nurse practitioner every week when they initiated the trial, along with clinic visits every month for the first 6 months, followed by home visits once a month and then clinic visits every 3 months. Patients randomized in the NOTCH trial were put into two groups. One group could be what's called the continuous oxygen therapy group, or the COT group. The second group was a nocturnal oxygen therapy group, or called the NOT group. Both groups had timers placed on their concentrators, and both groups received close follow-up care in the homes. So what the NOT trial was trying to do was not to determine whether oxygen per se was helpful, but was trying to determine people who had resting room air hypoxemia, whether using oxygen continuously was better than using only the oxygen at night when you were asleep. So it was looking at essentially duration of therapy. Should you be using it every day, all day and night, or only at night? So what did the study find? Well, the study of about 200 patients also demonstrated a huge survival benefit. So patients who were in the continuous oxygen group, about 100 patients, compared to those in the nocturnal oxygen group, about 100 patients, the group that were randomized to the continuous oxygen group had a relative risk of death of 0.5, meaning that you were twice as likely to live if you were randomized to continuous oxygen therapy. So that's one finding. So this complements the results of the MRC trial by saying not only is oxygen helpful, but using oxygen continuously, if you have resting room air hypoxemia, actually save lives more than just using oxygen at night. The second interesting finding of this study is that this is a group that was relatively adherent. You can see that the oxygen timers that were attached to the concentrators demonstrated that the patients randomized to the continuous oxygen therapy group used oxygen of at least 18 hours a day, compared to the nocturnal oxygen group, which you're only supposed to be using at night. They were using it 12 hours a day. So if I were to restate the findings, what it demonstrates that if you're relatively adherent to oxygen throughout the day, i.e. mean of 18 hours a day, you're far more likely to survive compared to if you only use oxygen at night. So what's happening in the real world? So based on the MRC trial and the NOT trial, CMS, our primary payer for oxygen therapy in the United States, has authorized and pays for supplemental oxygen therapy in people who have resting room air hypoxemia. There are other indications, of course, but I'm speaking specifically about resting room air hypoxemia in people with COPD. So if you look now and see what are actually people doing since oxygen use has been promoted, the study by PELICAN and colleagues published almost 10 years ago is very interesting. They followed 930 patients who had a diagnosis of COPD and prescribed long-term oxygen therapy for a mean of 3 years. They had objective adherence monitors using essentially looking at the counter clock that's available on most oxygen concentrators. And they also weighed the liquid oxygen container at each delivery. So for people that also had liquid oxygen, they were able to measure the amount of liquid oxygen that was used in between deliveries as a way to estimate using objective metrics whether or not the patient was adherent. And based on all of this, they found that only 45% of these 900 patients were using oxygen at least 15 hours a day. So meaning that about half, or I should say less than half, of the 900 patients were actually using the oxygen as intended, which is really for most of the day, if not all day long. So there's a lot of people who are not fully benefiting from oxygen therapy. One of the most interesting findings is what were the predictors of adherence. And what they found was that individuals who had received education by nurses or physical therapists ended up demonstrating greater adherence to their oxygen prescription. So this takes us up to the current study, which is the PELICAN trial. We've done some focus groups with patients and caregivers with COPD, and what this slide summarizes for you are the overall findings from the focus groups. So let me summarize a little bit some of the background, which many of you on this call will know, that about 1 million people in the U.S., predominantly those with COPD, are treated with supplemental oxygen. And while we know that appropriate oxygen use can save lives, we also know, both from studies like those from PELICAN and colleagues, but also our clinical experience as clinicians, that adherence to oxygen use is poor, and that we feel that overall many people are not fully benefiting from the oxygen therapy. Our focus groups indicated that patients and caregivers reported a need for reliable information, and in fact they recommended and suggested the need for peer coaching about the use of oxygen. What peer coaching means is essentially hearing from other individuals with COPD, other caregivers who are providing care for people with COPD, about how best to use the oxygen, essentially tips of the trade, if you will, coaching from one individual to another with a like condition about how to manage using the oxygen. One of the quotes I really like the most is right here. One of the individuals mentioned that I need an oxygen class, just like I get when I go to a diabetes class about the use of oxygen. One individual literally said, I needed coaching, if you will. We found that it wasn't just the new users of oxygen that needed some help and assistance about how to use oxygen. Many of our patients indicated that even if they've been using oxygen for years, that they felt that they still needed some coaching and assistance about the use of oxygen. Many of you know that oxygen prescriptions change over time. So what the oxygen prescription was 1 year may not be the same thing another year. Patients' symptoms change over time, and I think we need a structure in which we can provide continuous coaching for patients who need it. So this brings us up to the present, if you will. I was fortunate enough to talk with a number of patients and caregivers, but also build a relationship with the COPD Foundation, which, as many of you know, is led by an individual with COPD, John Walsh. The COPD Foundation, many would say, is the nation's premier organization that acts as a patient advocacy organization for individuals with COPD. And the COPD Foundation has long recognized the need for patient education. They have developed some terrific materials that are easy to understand in patient-friendly language. There are these booklets that they've created for patients with COPD. And what we were trying to understand is there a way to get the information in these booklets out so more people can use it through a coaching program, essentially unlock the wisdom that's in these booklets out to patients. So the University of Illinois, where I work, along with a number of other individuals from different parts of the country, we built what's called a PELICAN curriculum, which is a curriculum that is based on the information in the booklets, but actually can be delivered by phone by what we call the COPD Foundation information line. The information line is actually part of the COPD Foundation. It is staffed by individuals with COPD and caregivers who have a 1-800 number toll-free line that individuals with COPD can call to get tips. And so we help build a curriculum that takes the information in these booklets and actually integrates it as part of a PELICAN educational curriculum. It is a 5-session long curriculum that is delivered over 60 days, and the session topics are listed here. It includes information about the oxygen prescription and the equipment that they may have at home, talks about the importance of keeping your doctor's appointment and maybe goals to set for yourself when you go to the doctor's appointment as well as at home. What should be the goals that you should set regarding the use of the oxygen, as well as physical activity and self-management and so forth. We really stress the importance of maintaining an active lifestyle and how to handle situations where you might get short of breath. We talk a lot about what's called outcomes expectancy, which is essentially to help people understand what oxygen can do for you so that you have realistic expectations of the value of oxygen, and perhaps also to provide some feedback if you have some fears or anxiety about oxygen, such as whether or not I would get addicted to oxygen. So trying to lay out, if you will, using evidence, what are the things that oxygen can do for you, and what are the things that oxygen doesn't do to you. It also includes a set of reminders, as well as some opportunities to remind you about coordinating care among different providers that you might have. So the PELICAN curriculum, in summary, is an evidence-based curriculum built on the foundation of the work that the COPD Foundation developed that can now be delivered by phone over 5 coaching sessions over a 60-day period. So what are we doing with the trial? So you've built the curriculum, right? So what I've shown you so far is that oxygen works, it saves lives. If you have resting room air hypoxemia, you really need to be using it 24 hours a day, 7 days a week. And the more you use it, the more benefit you get. Using it at night alone is not enough, and using it at night, using it not at all is obviously the worst case scenario. We also talked a little bit about the fact that many patients who are prescribed long-term oxygen therapy have different difficulty with adherence for a variety of reasons, and that most patients are actually not benefiting from life-saving therapy. And then we've talked about the COPD Foundation having developed an appropriate educational curriculum, and that we as researchers have helped them develop, if you will, a phone-based curriculum that could unlock the information in the booklets. So the goals of the PELICAN trial is that we want to evaluate and compare the effectiveness of this curriculum when delivered under different scenarios. So this is a trial in which patients will be randomized to usual care, what we call reactive PELICAN curriculum, or the proactive PELICAN curriculum. So usual care is where the patients receive education as per their usual practices. So whatever is the curriculum that is delivered in the hospital, whatever is the curriculum delivered in clinics, whatever is the curriculum delivered by the DME providers or home health agencies. So that's usual care. We know that usual care is highly variable. In fact, some of our work has demonstrated how variable it is, but we want to compare it to what's occurring right now in clinical practice. And we're comparing the usual care to what's called reactive curriculum. Reactive curriculum is essentially they get everything in usual care, plus patients are offered a 1-800 number toll-free number and the educational materials, those printed materials I just showed you that patients can take advantage of. They can read the booklets, they can call the 800 number, contact the info line and get information, versus what's called the proactive curriculum, in which patients get usual care plus the COPD information line actually calls the patients at home, does outbound calls, if you will, to contact them and to actually go through the curriculum in a proactive manner. So if you will, we're comparing economy class to economy plus to business class, if you will. Some of you may ask, why do you need to make these comparisons? The simple answer is until we can demonstrate through evidence that we can do better than usual care, no payer will ever pay for more than that. And until we can demonstrate through evidence that we need a proactive outbound calls made by peer coaches, payers will say, why not just do it where you have an 800 number and they can call you? So we're trying to understand better what is the value or what is the return on the investment compared to usual care when you have a reactive info line versus a proactive info line. So what are the outcomes? What are we measuring? How will we know that PELICAN is successful? We're measuring multiple outcomes. The principal outcome that we're evaluating is adherence to the supplemental oxygen prescription. And we're measuring it at 30 days, 60 days, and 90 days. We were originally doing this study as a post-hospital discharge study, but now we're actually opening it up to include anyone, even in the ambulatory setting. So they don't have to have been hospitalized. But we're measuring their adherence at 30, 60, and 90 days after enrollment. We're also measuring a range of what we're calling secondary outcomes. When I mean secondary outcomes, I don't mean less important outcomes. I just mean in terms of how the study was designed. Statistically speaking, it's going to look at adherence. We're also going to be measuring these other outcomes, but they may not be powered in the right way to have full confidence you've measured these appropriately. We are going to be measuring physical function, fatigue, sleep, emotional distress, anxiety, depression, also satisfaction. How well are patients satisfied they can carry on with their activities of daily living? And then, of course, we're looking at healthcare utilization, a key outcome for most of this, which is when you prescribe oxygen and people are randomized to the reactive or proactive curriculum, do they do better with respect to readmissions, with respect to ED visits, with respect to the need to be seen in urgent care? Who's eligible for the PELICAN trial? Well, this is designed to be what's called a pragmatic trial or a practical trial. It's intended to inform usual care, inform clinical practice. So we have very broad inclusion criteria. We're looking for adults who have a physician diagnosis of COPD, who are on supplemental oxygen 24 hours a day, 7 days a week, because they have resting room air hypoxemia. We're excluding individuals who are essentially eligible for hospice. That's a very different population. So we're looking for individuals in which the oxygen is meant as a treatment modality in order to improve quality of life and improve survival. So what's the role for respiratory therapists in this trial? What may be some opportunities for respiratory therapists to participate and be partners in the trial? First, we'll be more than happy to answer questions you may have about the trial and potentially refer your patients to the PELICAN staff. We certainly are very interested in your help in identifying and partnering with DME companies who could serve as partners in the trial. We're also interested in identifying respiratory therapists who may be interested in doing home visits or who may already be doing home visits about participating in the trial and collecting some of the adherence data that we will need for the trial to be successful. And those of you that elect to participate with us, we would be more than happy to invite you to join us in interpreting the results and participating in writing up the results and publishing those. And then in dissemination activities, such as at meetings or conferences or websites, to help us find out how to get the word out about the value of PELICAN. And of course, one of the interesting opportunities in talking with Tom and others at AARC is that there are many ways in which we're thinking about what the next project might be, including potentially evaluating and measuring the effectiveness of doing home visits in order to do self-management education at home in partnership with respiratory therapists. So with that, let me end with acknowledgments. This project called the PELICAN trial it's really been a team sport in many ways. And while I'm from the University of Illinois, I've already mentioned to you that the COPD Foundation is a key partner. Tom Kallstrom is actually on our external advisory committee, and we've had other individuals who are respiratory therapists that have helped design the trial, such as Scott Soretta, who works with the COPD Foundation. I've given you here a list of it, and a range of other partners who are also involved in the project. And with that, I think Kim and Tom, I'm going to turn it back over to you, and happy to answer any questions.
Thank you, Dr. Krishnan. That was a great overview, and really a project and a study that I think really is an important one for us as we look at providing the best and the higher level of education and support that we can give our patients so that they can better self-manage their disease. A couple of questions I was going to ask to kind of get things started. To do this, if I'm at a hospital in the Midwest somewhere and we're interested in being part of this, or my DME is, do we have to get an IRB approval for this?
Good question, Tom. Thank you so much for asking the question. We've discussed the IRB approval requirements extensively with our IRB. We're looking right now to enroll patients in the homes. So as long as we're enrolling people in the homes directly, our IRB has already approved enrollment in the homes and will serve as the IRB of record, no matter where in the U.S. the patient's being enrolled. So, and the process is such that we are only asking for respiratory therapists and others who may be interested in being partners to hand out a flyer, and the flyer basically has a toll-free number that patients can call if they're interested, and it's really up to the patient to call us. And as long as they're calling us and they're the ones interacting with us directly, there's no need for additional IRB approvals.
Great. We have another question. I think this might be Deb Skis, perhaps. She wanted to know, is there a cost to the patient for being part of this study?
It's a great question. So the answer is no cost. We are testing essentially different ways in which we could provide self-management education and help patients feel confident about the use of oxygen. And as part of this project, we're providing this PELICAN curriculum. Essentially, they have to be willing to be randomized, of course, to usual care, the reactive or the proactive group, and whichever group they're randomized in, there will be no cost to the patient.
If a respiratory therapist was interested in participating in this, are you expecting some level of experience that they need to have had?
Well, we certainly are very interested in working with individuals who are clinical respiratory therapists as well as research respiratory therapists. And as long as you're a registered respiratory therapist, I think you have the background information in order to join us as a partner in the trial. We, of course, would want to talk with you some more, tell you a little bit more about what your role and responsibility might be, and would be offering you some training as it relates to being a partner in the trial. We're not looking for individuals necessarily to have already had research experience. The purpose of the trial is really to study whether or not PELICAN works in the full range of patients who are prescribed and using supplemental oxygen. And if we were to limit it only to patients of research respiratory therapists, it would dramatically limit the applicability potentially of the trial to the much larger patient population. So in short, Tom, the answer is we're looking for partners who are registered respiratory therapists who who take care of patients with COPD, and they do not have to have prior research experience.
Great. Another question, and this is from Frank Salvatore, our president, actually, he's online. He was wondering if participating hospitals that are part of this, do they need to have the IRB approval from your institution on file as they move out to do this?
Sure, that's a very good question, Tom. So the way that this has been explained to us in multiple ways is that this is considered a minimal risk study because we are providing essentially self-management education. It's really the patient that contacts us, and they're the ones giving us the information in order to participate. We do an informed consent on the phone using the University of Illinois' IRB-approved consent forms, and we do a phone consent. All of this has been approved. So as long as the informed consent process is occurring in the homes, so after hospital discharge or perhaps potentially after a patient goes home and gets their oxygen delivered at home, then there's no need for additional IRB review. If, however, individuals are interested in enrolling their patients while they're in the hospital before the patient goes home, So the recruitment process and the, if you will, the obtaining of informed consent, which we can still do by phone from the University of Illinois. So if we're going to be obtaining informed consent in hospitals before the patients go home, then yes, we will need IRB review at that hospital. And then our institution, the University of Illinois, would also need to review that the appropriate steps were taken in, in obtaining IRB approval at the other hospital. So in summary, if the informed consenting process occurs in the hospital before the patient goes home, it will require IRB approval and review at that institution. If we structure the recruitment to occur in the homes, and all that our partners are doing is giving a flyer and encouraging patients to read the flyer and call us if they're interested, then and all of this is done at home, then no additional IRB review is required. Our IRB at the University of Illinois becomes the IRB record for those patients recruited from home.
Very, very good. I have one other question, then I'll turn it over to Kim. In regards to the peer coaches and the proactive arm, when they're allowed to call the patients, is there a limited number of calls they can make, or as many as they need to?
That's a great question, Tom. So the way we've designed this is that there will be 5 structured sessions, 1 through 5, and shown on the slide here. And we will also take what's called PRN calls. So if the patient gets call number 1 and then decides that they want a little more information, or it wasn't clear, or a new question came up, they can also call that toll-free number and get additional calls. So it's a minimum of 5 calls, and they can have as many calls as they wish. What we're trying to do essentially is to connect patients with other patients who are working as part of this info line in the COPD Foundation, is to engage patients with resources that are available in the COPD Foundation community, and by so doing, I think, give a sense to patients that there is help out there when they have questions, and they can get reliable information through the strategies that we've just developed.
Thank you. Kim Wiles, do you have any questions you'd like to present or add comments?
Yes, I do. Thank you, Tom. Thank you, Dr. Krishnan. That was great. I did have a question. When you were talking about eligibility criteria, and you needed a minimal diagnosis from the physician of COPD, is there any kind of values, FEV1s, or anything that you're looking at? Because a lot of times we find in the home that we get diagnoses of COPD when we actually get in there, they're really not COPD. They might have some underlying lung disease, as pulmonary fibrosis or something. So I guess what I'm asking is, do we need any kind of confirmation of that COPD diagnosis, pulmonary functions or something in that regard?
Yeah, thank you, Kim. That's a terrific question, and this is a question that we've really spent a lot of time thinking about, is how much certainty do we need that this patient really has COPD? How much certainty and how much information do we need about other things that they may also have that is contributing to their hypoxemia? And what we ended up coming down to is this notion that there's 1 million plus individuals right now in the U.S. that have a physician diagnosis of COPD. We know that probably fewer than half of them have spirometry confirmation that they have COPD. We also know that a substantial number of them, I don't think we have very good estimates of exactly how many, but many of them, maybe a third, maybe 40%, also have asthma. So many of patients with COPD also have other lung diseases such as asthma. They may have concomitant pulmonary fibrosis. There's actually a clinical condition called combined pulmonary fibrosis and emphysema. Some of your callers may know this is a relatively rare condition, but people can have interstitial lung disease and obstructive lung disease. They can have COPD and sleep apnea. They can have any number of other conditions, of course. So what we ended up deciding is we wanted to do a project that would apply to the broadest set of patients. And yes, we will want to know if they have other diagnoses, and we will record them, and we will try to understand the extent to which additional diagnoses either makes the PELICAN intervention more effective or less effective, or easier to carry out or less easy to carry out, but we want to be inclusive. We thought a lot about whether or not to require spirometry to confirm a COPD diagnosis. This issue of confirming the diagnosis of COPD is actually one of the research topics that we have worked on. We've actually published papers on this exact issue. And we decided that if we were to require spirometry for a COPD diagnosis, that many patients who are on oxygen now at home will not have had spirometry, and so we could exclude them. But then you're limiting the study to the subset of people that have spirometry diagnosis. So what we want is to confirm what their diagnosis is and what information they have, but we're not currently limiting the study to only those that have had spirometry in their diagnosis. I think that what you're asking about is an important topic, and I'd be more than happy to talk about it in more detail with folks who would like more information about this. But this is one of those where there's no perfect answer, and we've decided to keep the study simple, if you will.
Okay. That's great. And, I had another question. I say Deb Skees also has, similar to what I was going to ask. I'm going to read Deb's question here. At my hospital, RT does do patient education at the time of discharge on supplemental oxygen. Does this intervention alter the data for patients we might refer? So, I know in our area as well, there's a lot of hospitals that are starting to implement programs prior to the patients going home with supplemental oxygen, and they're giving them some extra education. Will that alter your results, or will they be put into maybe a different category, or how will that work?
Yeah, that's a great question, Kim, and this is something I think we need to think about some more. And in fact, I think your feedback today is helping us understand the need to collect information about what the usual practices are in the settings in which patients are being recruited. We already know that usual care, and maybe this is sort of an interesting issue, but maybe we should call it usual cares with an S, because usual care is a huge, it's a substantial variation where I think some hospitals, some clinics, some respiratory therapists, some physicians, some nurses, some other individuals in some cases are actually doing a lot of what the PELICAN curriculum is intended to do, providing patients the education they need in order to use their oxygen correctly. What we do know also is that education is often provided once, or maybe twice, or maybe multiple times, but often limited to a particular setting where the clinician is working with the patient. So maybe a few times while they're in the hospital, or maybe once or twice when they're at home, but often never in an extended way, and certainly not in a way that patients can call to get additional information as they need. So we believe that the PELICAN curriculum is not only comprehensive, but is also flexible and can be tailored to the needs of the patient so they can have other additional information if they so need it. So what I'm saying essentially is that we will take all comers, regardless of what additional education that they may have. So that's if the usual care in that particular hospital is they get education from a respiratory therapist, that's great. In fact, we want patients to receive education as per usual care. But what we probably ought to do, and I will take this down as one of the things I've learned today, is we need to record a little bit about what usual care is, so that as they get randomized to either remain in usual care or to the PELICAN curriculum that's reactive or proactive, we can also determine what kind of education they received in the hospital affected potentially the additional benefit that may accrue from being in one of the PELICAN arms.
Okay, that answers my questions. I guess I do have one last question, I promise. If we have individuals on the line or in the future that would like to participate in this and help you out with this trial, what are our next steps?
That's a great question. I really am looking forward to working with a respiratory therapist and AARC. And I guess I might ask Tom and yourself to help me see what the right way is. So one option is obviously people can contact me directly, and maybe I can give you that contact information, or perhaps you could send it to your membership if they're interested, or maybe I can help write a small piece of information that goes in one of your flyers or on your website so people can go there and contact me directly. Or if AARC prefers, I'd be happy to work through you, Kim or Tom, to find the right way to connect. This is really a new thing for me, frankly, to kind of reach out to other professional societies, and I'm finding it actually fun, and I'm learning from this conversation. So how exactly we do it, I'd love to get some feedback, maybe from you, Kim and Tom, about how best we should structure this.
Thank you. That's a great question. I think we have a slide actually that we have prepared that will be shown as we complete this. But I think, yeah, definitely reaching out to Dr. Krishnan would be great. Or the other option would be you can send an email to me, and my email is Karlstrom@aarc.org, and I'll get back to you very quickly and forward your information on to Dr. Krishnan. So again, I think this is a wonderful opportunity for us to really make an impact as respiratory therapists on this important study. And also then as we look forward to other potential types of interventions and studies for us to be involved even more to the point where we're looking at respiratory therapists in the home and outcomes measures of that also. So again, I encourage all of our members who are on the line today or that know others that might have an interest to go to the archived version of this. We'll have that information out later as to how to access that as well.
Tom, if I could add to this, I think from my standpoint, I'm thinking that as we work together, and I'm very interested in working with the AARC on this, is that I think we'll learn about how it is that researcher communities that perhaps haven't worked as closely with the AARC could work better together. So we're going to learn from this experience. But I think that really moving forward, I would love to come to the AARC earlier in the process, and maybe for us to build projects jointly together that are of interest to you and to your community. And how might we help each other build the very best project by having some interdisciplinary working groups think about what are the kinds of questions that respiratory therapists want answered that affects their day-to-day lives, for which there is no good answer. This is a wonderful time in healthcare delivery research or healthcare delivery sciences, where there's actually funding opportunities now for big projects that answer everyday practical questions. And I'd be very happy and eager to work with the AARC and to develop those projects, and the AARC could lead them. I'm happy to support them and provide input, or I could lead some of them. We'd be happy to work it out in a way that's most attractive to the AARC. But I think this is our time to work together to identify questions that need to be answered, and then to develop a study that is appropriately designed to answer that question.
I agree, and I think that with our members who are on the call today and others who listen to this and hear about this, I'm sure this will generate a lot of interest as we move forward looking at this. So, Kim, did you have any final remarks you'd like to make, or Dr. Krishnan, before we sign off?
No, I just want to thank Dr. Krishnan for joining us and giving us this opportunity, because I'm with you, Tom. I think this is a great opportunity for this and just for the potential of additional studies in the future that we can work on. So, we just need to recruit our patients, get everyone involved.
Thank you.
Great. Thank you, Kim, and thank you, Tom, and to the AARC. I guess from my standpoint, I'm really thrilled to have an opportunity to talk with you today, and looking forward to really working closely with AARC and its members.
Very good. We look forward to it as well. So I'd like to thank all of you for joining us today, and I'll sign it over to Shauna at this point. Thank you.